Now, we are at the KICC, at the Nation Health Summit, because this is what we do. When we say we're fixing the nation, one conversation at a time, it's not Eric or Mariam or Janet that are going to fix the nation. It's all of us collectively. That's why we bring the mic so that we can all have a conversation. Today, it's all about health. And Jano, you chose a good quote for the day today. What's today's quote? Today's quote touches on mental health, and it's from a specific athlete who I really enjoy, a sportswoman whose outlook on mental health I really like. She's called Simone Biles. She's a gymnast, an Olympic gold medalist, and she said mental health is something that we can't see, so it's hard to talk about. But I'm here to say that it's okay not to be okay. And we just had some of that conversation, I think, earlier, Latif, on your panel. Yeah, it's okay not to be okay. First of all, just a random reaction to that particular quote, and I'm going to give it to you. You can introduce yourself and tell us what you do, and then tell us about that quote. What does that quote say to you?
Thank you. Thank you very much. My name is Fred Kokeu. I'm a health economist working with RFH Healthcare. So we work together with Dr. Lalit, changing healthcare and changing lives. The quote itself means a lot. Of course, it's never wrong to say you're okay, all right? The assumption out there, and I want to speak for the boy child, is that the boy child should never cry. And what then do we advocate? We tell them to shed a tear, not necessarily in public, but sometimes do it in private. Of course, it is okay to say you're not okay and speak about it. That is the very much pretty what we say. And of course, just the beginning of getting okay is to be able to expose yourself out there and say you're not okay, so that then you're able to get a solution. Thank you.
It's about being vulnerable, Janet.
It is, and I like that he spoke for a population that is often told, man up, don't cry, and say, no, it's okay not to be okay. What are your reflections on that as well? Your name, who you represent, and how you feel about that quote?
My name is Yvonne Koller. I'm the CEO of LACO Insurance Agency. Just to add on to that, most of my time, I talk to many clients, and we realize that the simple things that we tend to assume, like not being okay at home, maybe you had a small altercation with your partner, or your kids are not doing well at school, those things pile up. And when they pile up, we get stressed out as parents. And when you don't have someone to speak to, it gets hectic. So what has the insurance done? So currently, underwriters, we partner with underwriters who have affordable products, and with this product, they have covers that cover psychiatric health, mental health, and they have actually increased the limits. So what we encourage people is you can get up the insurance products, and then you're able to talk to counselors, and you're able to get the help that you need. So it's okay to talk to someone, and try as much as you can to express yourself, and don't bottle it up.
You know, also, and we had the GM from Minet earlier in the panel, Edwin. Edwin, she's talking about, she's brought in the insurance. So see, Mimi, and your Millet. Insurance, we always think of insurance as a cost, as a burden, as, well, even when you're sending us for health checkups, it's so that you know how much to charge us or when not to accept, us as your clients. Now, please respond to that. For the sake of our mental health.
Far from the truth. We don't send you so that we can not accept you under the scheme, but to be able to price accurately, because for the insurance program, it's important to be sustainable and be able to meet the obligations at the end of the day. But more importantly, just borrowing from what my sisters talked about here on mental health issues, I would say that we at Minet have embraced mental health in such a way that we run a program called Employee Assistance Program. And in the Employee Assistance Program, employee wellness is not just the lack of a disease, but really just looking at the wholesome person. So we talk about emotional health, we talk about social health, we talk about financial health, in addition to just your physical health. And so through that, what it means, it's okay to say you're not okay. I would pick an example. If somebody is having financial challenges in the current day and age, we have seen lots of people going into habits such as betting, and they end up at a loss and they don't have money to run the family. So it's important to know that there is help even in that circumstance, that you can reach out to Minet. And Minet, through our counseling center, we have a counseling center which is domiciled at our headquarters, which supports walk-in clients, but also telecounseling, where we can give help as far as Turkana, as far as Lamu, and somebody can call in even in the middle of the night and say, I'm having a challenge in this area and I need help, and we're able to assist.
Mm-hmm. I wanted to see if we could get, before Mariam comes in, a quick reaction. I think you'd spoken about motivation, a motivation for health can lead to motivation for insurance. I may have misquoted you, but just explain how you think we can tie that into access to insurance.
Good morning. I'm Dr. Shilpa Mulki. I'm a physician at Lion Sight First Eye Hospital. We deal a lot with diabetes, and of course, mental health is a big part of diabetes. Not only diabetes predisposes to mental health issues, but mental health issues can happen along with diabetes as well. Increased prevalence of depression and anxiety. Now, I like that you brought up the telehealth thing, because a lot of our patients don't know how to access, and it's a stigma for them to access. Remember, most of the clients that come to us, or persons living with diabetes that come to us, are those of a slightly elder age group. It's a huge stigma for them to accept and say, I'm not okay, right? So encouraging them to say that, not only with mental health problems such as anxiety and depression, but also with dementia, early onset dementia, to screen for early onset dementia. As an insurance, I don't know the numbers, but as an insurance, wouldn't it be worth it for you to have more screening programs in place, encourage and motivate people to screen themselves early? I had this idea that I discussed with Janet. If I'm to submit my step count to you on a daily basis and show you that I'm keeping up my health, do I have an incentive from my insurance?
Like a credit score for insurance for your
Yes,
health.
that's
You're
a good
taking
metric.
care of your health, and if you show it, then
Your premium should be lower.
Yes, exactly. So why not? I mean, that would probably reduce your costs, and it would motivate somebody, and I think it would impact overall.
Yes, indeed. And that's an area that we are venturing into. Very soon, we'll be out there just launching a program that will take into cognition some of these health steps that people are taking. Health practice, for example, walking, how many steps you're able to make in a day. That should then incentivize us to be able to pass on a discount or be able to encourage you more by subscribing into a gym to enhance your health, just to promote your better health. But ultimately, when we have better clients who have better health profiles, it means then eventually we will not have as many claims, and as such then the programs will become cheaper and cheaper by extending discounts to the programs.
Okay. I want to look at it from a bit of a structural perspective. Universal healthcare is a word we hear, but from practitioners and from the people sitting here, what does that mean for you? As an oncologist, what does it mean for your patients if universal healthcare was working in Kenya? From Dr. Rizwana as well, working with diabetes and of course with eyesight issues, what would that mean if universal healthcare worked? And from Minet, would it put you out of business? Well, let's hear it first, of course.
So as an oncologist, universal health care would mean, complete care for my patient, right from the beginning to the end, that they undergo the complete treatment process without any delay, and it should be adequate with regards to that patient. So for me, that would mean, because outcomes in oncology totally depend on adequate and proper treatment. So for me, that's the most important thing.
Are you able to speak to, for example, survival rates and how they would shift if there's earlier screening and better screening, and then, of course, care is taken care of financially from beginning?
So with regards to the finances, I think that's the biggest challenge when it comes to treating any cancer patient. All the discussion ends in with finances, with adequate insurance, whether the patient can complete the treatment. So it is very important to counsel patients, what they're going to undergo, because cancer treatment takes a lot of time, involves a lot of money, involves a lot of other things. So one needs to inform the patients adequately.
Right. And this is open to everybody. What does universal health coverage mean for you? What could it change in your life, in your family's life, in your patients' lives, in your clients' lives, etc.? Yeah. You want to answer? Okay.
Okay, thank you for this opportunity. My name is Stella Mwangi, a statistician by profession. When it comes to NCD and universal healthcare, in terms of this conversation, I feel like it will be more important if the awareness is, if you increase the level of awareness that we are doing to the community, because you need to, if we're moving towards preventive and curative healthcare, you need to be able to convince that mwananchi who is not sick that despite the fact that you're not feeling bad, you still need to go for screening to prevent any risks, before they become too big to handle. So yes, it's basically increasing awareness can increase the prevention that is there. And I think that's going to lead us to the next step of universal healthcare as well. Thank you.
So it's a great point. Yes.
Thank you so much. I think when we talk about universal health care, and of course from my team's perspective, let's look at number one, accessibility of the health itself. All right? And again, I know the intention of the sitting government is to help Kenyans be able to access healthcare. And if you look at the manifesto, you're able to see that is well tabulated, that is well stipulated. But then now, are we really implementing that access just before we then go back into the actual cost? Because yes, the cost is going to be, catered for, but are people able to access, that kind of service? So be able to go to mashinani and be able to have people get to know that your service is catered for. All right. Now we go back to the sensitization aspect that she's talking about. I'm looking at a lot of new comings in the health space in Kenya, for example. And just a week ago, our government then says there are certain parameters that are covered under SHA, for example. Are Kenyans aware? No, right? I still have my village mate in Migori struggling to access critical care. Yet the government says critical care is covered a portion. So when this information goes to wananchi and that service provision is with them, all right? So you only need to walk a kilometer or two and be able to access that. Then we are going to realize that aspect of universal health coverage. Now, in terms of facilities who are partnering to be able to serve, can we have one universal rate for everybody? All right? So then there is no supply induced, such kind of things. There is no information asymmetry coming across. Guys are not informed. Others who are informed are taking advantage of others. So once it is universal, then we are very confident that we're going to achieve this, so that then public facilities together with private entities partner and complement each other in service provision against the notion of competition. Thank you.
I like the way you've said it. I just want to, before you come in, Edwin, you are a health economist, okay? So you look at the costs of providing the care, the costs of, the citizens' affordability for it. Where is the sweet spot in making sure that then that this healthcare is affordable? It's accessible. That means that there is proper investment at, community level, but also then it's affordable to those who are going to seek.
Thank you so much. I think it literally boils down to the actual cost of service. And we all agree that people who are in the health space knows the actual cost of doing a full mammogram, for example. And I think where I sit, a full mammogram, the cost should be about 300 shillings. And that is on the higher side. So the question is, why would somebody charge 1,500, 2,000? Yet it should be about 600 to 800. So once we are able to achieve that aspect of making sure we cost these products to be able to meet the actual needs, and we base this on the actual cost of the utilities, then I don't think we are going to have an issue, because everything is going to be universal. Like just like I had said, everything is universal. Everybody else accesses the same care. Look at the first world countries. If you look at cost vis-a-vis accessibility, sorry? If you look at the actual cost of service, everything is universal. You look at UK, for example, the health system is universal. So they know very well when you walk in Nairobi and you walk in Kisumu, the cost of healthcare is the same. Unless otherwise you go to different tiers of facilities, then you're able to get an escalated care. So I think that's what would probably make a change. Thank you.
Okay. Now, I was just coming in to say that indeed, just banking on what my colleague there has talked about, having universal health coverage and standardizing costs of care is going to positively impact even insurance, because it's not that universal health care is going to cannibalize our business, but really is going to support our business by providing a standard coverage for the general public, and therefore, first of all, bringing into the fold the uninsured population, therefore extending the knowledge of insurance to a wider population, which means then making the work of insurers a little bit more easier to be able to convince members of the public that now that you have this basic coverage, and if you need any extra coverage, then we can step in and provide that coverage that possibly cannot be provided within the universal health coverage.
Mm-hmm.
If I can just add to this, as far as universal health coverage is concerned, right at the basic level, screening, which is critical, needs to be provided for. So it's very important for the package to be such that patients should be able to get basic screening before they are able to be covered for other treatments. Unfortunately, I think in the current structure, not all screening is covered. So what is happening is in as much as somebody will have, for example, a shock cover, they will first have to pay for the basic screening and basic medication. It's only if they need more support is when they're able to get this. Whereas if you want to make it preventative and if you want to carry everyone on board, I believe that more screening will make it easier for them to buy into this program.
Yeah, thank you. Also, just to add one sentence and not to repeat what others have said, I think for me, UHC, universal health coverage means affordable, accessible care to those that need it at any point that they need it. So it has to be available, accessible, and affordable. And that, I think, if we can look at the government ecosystem, that is falling short in many ways. But just to go back to the issue of the insurance and looking at blood donation, I talk about blood because I want blood to be on the agenda of everybody's mouth and head from today onwards. And I hope after this you're going to donate blood, all of us. You know, go. there's a blood camp going on. Yep. And I want to tease this to the insurance companies. Blood donors sometimes need an incentive. Mm-hmm. They have no incentive apart from the soda and bread that they get. They need some incentive. I want to toss this to you and suggest, is it possible to start an incentive scheme for blood donors in the insurance company? Because blood donors save you a lot of money. When a blood donor has given a pint of blood, they've probably saved you one day in ICU, which could be 100,000 shillings. This donor is not getting anything apart from bread and soda. Can we have a situation where a blood donor is able to get a rebate? You pay lower amounts of money in terms of the insurance premium. For example, if you are a regular blood donor, you get a discount, maybe 5%, maybe 2%, because that blood really helps the insurance company to save on costs. And it also helps the patient to get discharged much earlier. And it helps surgeries take place. It helps cancer patients get treatment. So I think that would be a good thing to consider as you consider the NCDs, that also blood needs incentivization, and a rebate in insurance could be one way to go in that direction. Thank you.
Dr. Muluru, that's a good one. People are clapping. Just clap. It's okay.
Yep.
You know, and you'll respond to this later, because there are very many things that we'll tell. Tutawaambia leo nyinyi watu insurance. And I think it's a good thing and it's a big thing, because we for a long time have been talking about insurance companies, not just in health, but just general insurance and health insurance and life insurance, just operating from a level where our penetration is so low because probably of the attitudes that people have had and the experience that people have had with the insurance companies. And it's just time to open up and just think broadly from an individual company's perspective, from the Association of Kenya Insurers perspective, from the regulator's perspective, just all of you coming together and saying, okay, how can we better this? I'd like to move the mic back to some of the backbenchers. The question that Mariam had asked is, I mean, what is universal health coverage to you? But maybe now we can even turn it into, what are those barriers to universal health coverage from your own understanding? Raise the hand.
I think there was somebody here, Selena, who's been burning to share some thoughts. So maybe we can ask her to start.
Yeah. All right, then we'll move the mic over here.
It's already there.
No worries.
Selena can start.
Okay.
Maybe you can stand, please.
Yes,
so that
sure.
The mic can catch you. Mama.
Oh, I stand, eh?
No, the camera, sorry.
Thank you very much for this moment. Yeah, we've had a very good discussion from 7, and I was writing down some notes which I'll just go through them very quickly so that you people can understand them. My name is Selina Olwando Gweno, CEO, Children's Sickle Cell Foundation. We are also under the Sickle Cell Federation of Kenya, and I'm also a member of Non-Communicable Alliance of Kenya. I also sit in their board. And so I believe that a wealthy nation is measured by its health, education, and security. And so let's all think about it. If we have all those checked as working, then I think we are a wealthy nation. If it's not working, then we need to do a lot. So going on drugs and substance abuse, a lot was said, but there's something which we need to really focus on. Sickle cell disease, they use a lot of pain medication. Some of them even get to the dependency level. But our rehabilitation centers do not know how to take care of them. Something that you people need to think about. We talked about cancer screening. Very good. But I wouldn't go for screening because I know once I go for it, where do I get the care? Will I be able to afford it, if at all I am positive? So can we think about screening and access to care? If you can't link me to it, let's not talk about screening. About blood, blood is something that's very close to my heart because our patients consume it a lot. And I'm happy to say that we've been having initiatives in the various universities in this country, trying to collect blood, but still it's not enough because we collect this month, the next month we are being told there's no blood. So we need to apply other things like respond better to, people respond better to visuals. So can we have billboards? Can we have fact sheets going around? People don't even know what they should eat so that they can have enough blood to donate. And I'm happy that Terumo, COBA, Kenya National Blood Transfusion Services, and Kenya Tissue and Transplant Authority have been helping us to just try and create awareness, but it's not enough. So as a community, let's start now doing this every day, and everybody here should be a donor. If you're not a donor, then maybe you should volunteer your time to do that. With healthcare uptake in Kenya, we only go when there's an emergency. So let's try and strengthen the health system so that the emergency part does not become the first encounter of health. Challenges that we are having with the disease after diagnosis are many, and you've talked about UHC, you've talked about access to care, you've talked about community health promoters. Let's not burden our community health promoters with a lot of knowledge, and then we cannot support them when it comes to where do we take them, where do we send them, because these people still go back to them and tell them that you brought me here, now where do I go? Or they expect them to even fund their health issues. When it comes to health funding, becomes my favorite topic. And health funding for chronic diseases like sickle cell is still not there. We are talking of SHIF coming in, but then the private insurances are not in. And I say it without contradiction. Anytime you take that insurance, you are worried more about the insurance than the disease. I'd like us to have a conversation, this similar conversation, in a rural setup. And when I say rural, somewhere rural, I just try and ask the same questions. You'll be shocked at the answers you'll get. We are more polished, we are more exposed, we are more innate. Somebody in the rural setup or within the informal settlement will not be even thinking of taking up this, because some of the challenges they have are things like food, even access to care, even just taking a Panadol is expensive. And just quickly finishing into it is that after screening, then what? Who funds it? Who takes care of me? Who guarantees me that health? And then when we come to blood, we've talked about blood, but I think it's about time all of us start learning from a country like Zambia. Zambia is doing a lot, and their blood is not that they're sourcing out from outside, they're sourcing from within. to ensure that blood is available for everyone. I should never go to a hospital, I need blood, and then I'm told, call your relatives to come and donate. Who told you my relatives have blood? No, it's not fair. Then let's start pooling resources. And when we pool these resources, we are talking about bringing everybody together. The insurance companies are very good at looking at us from a distance. And when things are bad, they step out. I'm not saying it badly, but it's something that we need to start thinking about. What are these small things that you can do, even for a small community? You can imagine there's a self-help group. How can an insurance company come and guarantee them help in that small level without talking about risks and assessments and everything that then puts us off? And therefore, to finish this, is we have to also think seriously about water, sanitation, and hygiene. If every household can access proper water, sanitation, and hygiene, I think even our health issues will have reduced to a certain extent. Thank you very much.
Thank you. Thank you, Celine. As we battle a cholera outbreak, I think that's really important to note. There's so much to take from what you've said. Let me start with Dr. Triza, because you spoke about dependency issues and then how we deal with them. And a lot of times it seems that people who are fighting and battling addiction are not treated as patients, but rather, you know, there's judgment, there's castigation. So then it even discourages others from being upfront about what they're going through. How are we working towards bettering the medical system for addicts?
Thank you. I think for me, should I stand? Yes. Thank you. My name is Triza Mwangi. I work with NACADA. I am a counseling psychologist by profession. I think for me, universal health coverage should be affordable, accessible health care that is made available without exclusions. Insurance, hello. You find that some of the issues we are discussing today, like addiction treatment and rehabilitation, is an exclusion in most of the insurance coverage. And you find that you end up actually covering the addiction treatment indirectly. Because when someone suffers from kidney disease or kidney failure as a result of chronic alcohol use, you may end up treating that. While at the same time, if you actually covered addiction treatment, that would have averted, the other health issues that would come along. Again, when we talk about comorbidities in terms of addiction, we find that people who suffer from substance use disorders also suffer from mental health conditions and other medical conditions. And therefore, when you treat addiction treatment as an exclusion, then it means that you are not providing universal health care. And I think SHA is coming in to support that, because now there is a bit of coverage on mental health and also addiction treatment. However, we also need, and I think as an authority, we have been working towards reducing stigma towards the people who suffer from substance use disorders. Many a times, we brand them, we call them addicts, we call them many other bad names. While that may push them deep into addiction, we need now to try and start appreciating as a community that addiction is actually a disease. And most of the time, people view it as a self-inflicted, kind of disease, while it is not. Because we know that there is also the issue of being genetically predisposed to addiction. We have seen families that have suffered, many members of one single family suffering from addiction just because of them being genetically predisposed to addiction. And therefore, we need as a community to now start appreciating that addiction is a disease and try to treat those that suffer from substance use disorders as people who are suffering from any other mental or medical conditions. And therefore, when we work on reducing the stigma, we will encourage them to access health care, and we will ensure that those people amongst us that suffer from mental health conditions, addiction included, are able to get the care that they deserve. I have seen us do many harambes for people who are suffering from cancer and many other medical conditions, but I have never seen us support you know, people who suffer from addiction, like when we support other medical conditions. So it is in the same spirit that we need to treat our brothers and sisters who suffer from addiction and also try to support them to get the health care that they require. I know we have quite a number of rehabilitation facilities in our country accredited. However, most of those centers are privately run. So therefore, we have a few run by the government. We are supporting counties as an authority to establish, you know, rehabilitation facilities in the effort to make treatment, addiction treatment and rehabilitation more accessible and affordable to the Kenyan mwananchi. Thank you.
Well said, well said. You can pass the mic next to, you have the mic.
Yeah.
Wewe ni mrefu lakini simama tu.
Kamera itanishika kweli, but it's okay. Yeah, thank you, Teresa, for the discussion regarding the universal health care and especially regarding the mental health. I think that's my area. My name is John Kefodo, counseling psychology. I think when you talk to universal health care, I think there are areas that I'm not very sure the guys who sit down to strategize on what to consider as a package when it's coming to universal health care, because I believe there are health burdens that are really we are struggling with as a country. But I think the major area, only the physical conditions that we talk about, but when you talk on mental health, we have so many conditions, especially even with people suffering from other disorders, as bipolar and all that. But nobody really thinks about them. And even when it comes to even insurances and even the SHA, is it the SHA or the SHIV or the SHISHA and everything, you find that nobody is even thinking about mental health as an aspect of it. So I think as a nation, we can see the reflection on what is happening in our nation as a result of mental health. And so many people are even committing suicide and killing each other and all that. And all this is a connection to mental health and what is happening. And maybe the biggest question we need to ask ourselves as a nation is, even when we are packaging this universal health care and all these, are we thinking about the country conditions and burdens that we are having as a nation, so that even when we are packaging these, are we equalizing on what is affecting us as a nation and what we are suffering in as a nation, so that we can give access to all these services to anyone, not only in urban town or urban area, but even in the rural area, whereby nobody even knows on what we are talking about when you talk about mental health. And I think that's other areas that we need to think around.
Asante sana. And yes, a lot more to discuss, a lot more to unpack here. Even our community of fixers online, we can see you on YouTube. Mike, Smallest Ever, Lenny, you're engaging. They always do this, and it's a good thing. Let's just continue engaging. We'll pick some of these questions and bring them to the floor here. We are at the KICC at the Nation Health Summit, and there's a lot that's happening. It's free. It's the final day today. It started yesterday, and there are also some very many free services that you can access if you actually come. Free cancer screening, and some of those results that take long are actually coming out around the same day. You can get them here. Free eye check. Come and get free STI screening, testing and treatment. Free HIV testing and counseling. Free basic triage services. Free emergency rescue support. All that happening here. It's free entry. KICC, the Nation Health Summit. We are continuing here. Mike Ikokwa ground, discussing universal health care and what we need to do to improve on it. We'll be back shortly. Time for that quick break. Okay, there's a discussion that's happening on our YouTube fixers. Smallest Ever, Lenny, they are having an engaging debate. Smallest started by saying the government should allocate more resources to prevent diseases. We should excel in both prevention and cure, but the emphasis should be on prevention. Lenny said the government is very good at PR when it comes to the basics and very theoretical in both prevention and cure, but the emphasis should be on prevention, and says the policies and the talks are superb. It ends at that. Smaller said, Lenny, I think the solution is that we, the citizens, need to hold the government accountable. You know, The government doesn't care because they know that there are no consequences. Lenny comes and says, luckily we are gaining momentum on that. We should wait and we shout until they hear us. Smallest comes. That's true, Lenny, but here's a shout out. There's a shortcut here for a person with integrity and credibility to be voted in. If we do this, it'll be a win-win situation for all of us. Be ready 2027. The problem is not rigging the election, as many can say no. We can make it a too big to rig election. The real challenge is finding a person with integrity and credibility to lead. Mambo yote haya yanaendelea. It's about health. Okay. Everything that you've heard them talking about, it's the health conversation that we're having, Janet.
Absolutely. And you know, just as we were going to the break, I was speaking to her and asking myself, where is the gap when it comes to awareness? Because some might say, this is awareness if ever we saw it, right? The Nation Health Summit, it's been posted, whether it's on print, whether it's in the TVs and the newspapers, on social media, yet there still seems to be an awareness gap. Selina just mentioned it. She said, you know, it's really great that we're here having a polished conversation. How are we translating that in rural areas? And I was speaking to Mariam earlier saying, I'm quite vested in this summit because, you know, when you reach your second act in life, there's like a second act phase. And everything that the panelists were saying, I'm like, yep, I need to make sure I'm checking my eyes. Yep, I need to make sure. I was telling her, I realized that my thyroid gland now is not regulated for any medics. I'm so sorry if I'm butchering what I'm saying, but it means that it then informs me feeling, for example, very fatigued. I didn't know that, and I wonder then how many other people don't have that information. If we're here with this kind of access to information, then where are we going wrong in terms of even people who are perceived to be informed not having information? Blood transfusion, I've learned a lot today, and we were just saying with our colleague here that he was also saying he only first did it when he was in college. Kids don't know. So where are we going wrong in the awareness? Where is that gap? I think for me, I'm really, really curious that if in my big age there are things I'm learning now, then how are we making sure that other people are up to date and up to speed with information? Where are we going wrong? That's kind of where I'm coming from. So I don't know who wants to respond to that or participate to say, how do we make sure awareness is just all around?
Yeah, thank you very much. Thank you very much, Janet, for that detail. And I think you're spot on. Prevention comes with awareness. There's little awareness creation amongst population. And I think it starts with everybody individually. We must be attuned to the fact that we are vulnerable to disease, and there's a lot we can do to prevent those diseases. Basic things like road accidents, for example. The road design can be faulty. And we find so many accidents happening at a particular black spot. They even call it black spot because there are so many accidents there that you see a banner saying black spot. What can be done at that black spot to prevent that accident? If you just write black spot, somebody else might not see the black spot. And you'll find time and again accidents happening on the same place. It might just need redesign of that section of the road or putting some bumps somewhere. So I think we need to, and you can imagine if a road accident happens, you have 60 people injured. That pressure on the hospitals around there is huge. And of course, there's need for blood, there's need for surgery, there's need for everything. So I think we need to take prevention very, very seriously. When cancer happens, it doesn't happen day zero and it pops up. It has been there for quite some time. Thanks to smoking, thanks to alcoholism, thanks to bad foods. So you've been creating that cancer for 15 years before it pops up. Heart diseases, when they pop up, it's not just you went to the pharmacy or to the clinic and they told you have heart disease. It came because of hypertension. 20 years plus of hypertension without your knowledge. Diabetes of 15 years. Sickle cell disease, you can prevent sickle cell disease by screening and counseling. So once you screen the couple and you counsel them, and they're aware that if they proceed, they'll get a sickle cell patient. Some might opt not to. Others will opt to, but with the knowledge. So I think that knowledge has to be very, very carefully impacted at the school level. Yeah, primary schools, high schools, teach about in basic biology, not just about plant biology and insects. You know, talk about heart disease also in schools. So that, I think, would be very critical in terms of preventing diseases. And I must say that we must thank God for our beautiful bodies. Our bodies are really made to fight diseases, even without your knowledge. Eric, right now, your body is fighting diseases, and you have no clue about it. Your white cells are scouting they're checking for cancer, they're checking for other autoimmune diseases, and they're clearing them out without your knowledge. That's what God gave us, and we must protect that. So I think we need to create more awareness, more education, and with that then we'll support the healthcare system to have fewer patients. Because right now we're looking at the sick population. There's so much you can do with the healthy. 90% of the healthy, what can we do about this healthy to keep them healthy? So that those who tip off into sickness, the 10 people, the 10%, the insurance companies have all the resources to take care of these 10 people. But if 90 people are in hospital, then everybody is overwhelmed. Yeah. So really, awareness creation and prevention are key in this fight of universal health coverage. Thank you.
You've been saying yes. Yes. Shika Mike.
I'm sorry, I absolutely agree with you. I think we talked about prevention and then screening, and someone mentioned that after screening what? But it's at the level of screening that we pick up things and we can introduce small lifestyle changes sometimes in our lives that can prevent the full-fledged disease from coming to being. Screening means awareness. If I'm someone who is predisposed to diabetes, I have risk factors, I check every 6 months. I encourage everybody. A Shosh comes to my clinic, I'm going to ask the kids, are you the kids? Are you the children? Yes. Have you checked yourselves? No. I'll give them a prescription at your own time, in your own pace. Please, your siblings, check. If you're above 30, 35, you're at risk, check, please. Education is extremely important, and I think we had this discussion. Kids are much smarter nowadays than we had in the previous generations. I'm from the previous generations. But I know these kids can be educated. We had a project going on, and we, from Lions, in regards to the outreach camps, you teach the children how to hand wash well, they teach their parents, and it just works that way. You're not going to learn from television. The current generation and the older generation are not going to learn from social media. They're not going to learn from television. They're going to learn from the kids teaching them, because they don't really have a choice, or the kids are going to make fun of the generations. They're going to say, Mom, you're not doing it right. Do it this way. It's better. So I agree with you. I mean, education on the level of teaching the kids makes a healthier population for later on, lessens the burden on insurances, so you don't have to pick on people.
Yeah, insurance seems to be the topic for this morning. And I cannot let the mic pass me by. But just to say that over to an earlier discussion around sickle cell treatment and the assertion that insurance excludes treatment of sickle cell, I would just like to inform you that there's been a lot of progress in the insurance sector, and Minet has been leading a lot of that. We pride ourselves in managing the largest medical scheme in the Republic, and that's the Teachers Medical Scheme. And as well, we are part and parcel of the joint venture that manages the National Police Scheme. And in those schemes, we are able to support sickly patients with sickle cell, with even complex treatment like bone marrow transplant, which is deemed to help in managing sickle cell, among other treatments. So that is available under coverage. So the idea that insurance excludes this is not the case. There could be certain exclusions that are on your insurance program, but if you talk to us at Minet, definitely we'll be able to look into your program and redesign it to ensure that some of those challenges that you encounter are taken care of. Just coming back to the issue of sickle cell, I think it is prevalent in certain regions of this country, and what I've not seen is there being centers of excellence that are situated closer to the patients to be able to support patients, especially when they have crisis. And you find that most of them end up in high-cost facilities who may have the know-how of treating this, but sometimes it becomes very expensive. So I would challenge the government possibly to consider having centers of excellence in areas, especially I think parts of Nyanza region. Usually sickle cell is around water bodies, and that would help to reduce the severity of the condition. But more importantly also is to say that as we talk about insurance, as that has been challenged to us, we have embraced preventative care. So we carry out, as I said, health risk assessments, which help in profiling the population and catching diseases early on, and therefore reducing the exacerbation of that disease, which may lead to high costs, and thereby managing the cost of the scheme. We also have programs such as chronic disease management programs And in chronic disease management, essentially is to profile those people within the population that might be suffering from chronic conditions, such that we put them in a program that helps them to access care in a better way, to do follow-up so that they are, obliging to the regime that they've been given, in an effort to ensure that they do not complicate. So those are efforts that now have been embraced within insurance that were not there previously. Previously, all you did is purchase a medical insurance program, you're given a card, and off you go. But now we are more involved to ensure that we are managing the total cost of risk from prevention to actual treatment. We run programs on vaccines, vaccinations, and that's preventative. So we have opened up some of those things that were considered rigid in insurance.
Somebody has sent me a question, and they're saying, let's talk about neurodivergent disorders, autism and all, and how those as well are. Number one, how do you screen and know, especially for children and across the country? And then is there sufficient support in our health system that then also addresses that? Maybe we can come to you, Dr. Ari.
So if we talk about screening, I think, like I informed before, only 3 cancers are actually screenable, that is cervical, breast, and prostate cancer. But the uptake of screening is very less. I mean, if you take a quick poll in the audience here, I don't know how many of us have got a pap smear or a mammogram or a PSA done. So most of us are aware, we are aware that screening is required, it is useful, but we don't do it, for various reasons. So I think the message is that we need to definitely increase the number of people undergoing screening. That's very, very important. Have facilities for patients to undergo screening. Okay, and it should not be only centered in the big cities. It should be right at the grassroots level that screening is done, and facilities to transfer positive patients to a cancer facility. That's more important. I mean, once you screen, you need to treat, and there are certain situations like for cervical cancer, there is screen and treat, where screening and simultaneous treatment is also done. So that is being done by the government of Kenya at the county level. So that's really useful.
Sorry, so that someone here wanted to speak on a little bit on the preventive side before we moved to the neurodivergency, but let's just hear from you.
Right, so good morning. My name is Edward Macau. I work with BF Suma. BF Suma basically deal with supplements. And on the part of the preventive and the awareness, one thing I think we should do is mostly on educating people on the importance of why I should do the screening or why should I know something about this and this. Because maybe on the screening side, most of the times we might visit maybe the rural sites. And sometimes you approach somebody, you tell them we have a screening there, you can come and check your health status. And that person will be like, it is not, I don't want to know it, because when I know it, it brings me some other stress or something that I didn't know. Or you guys were going to tell me, maybe I have a problem that I didn't have. But you've been able to screen that person and you've been able to share with them, show them that you have to check your health every now and then. And also, maybe preventive. We also, like for our company, we're basically more on the supplements. Sometimes people take it for supplements, maybe you cannot be able to take it, or maybe I'll just go and get something else. Because supplements is basically on the part of maybe something that your body, the nutrients that your body needs. Because most like the chronic kind of diseases, from some of the knowledge that I have, is that they're not brought about by any bacteria or anything. It's just about my lifestyle, what I've taken every day, what I've been able to consume from this day to this day. Maybe I've had a problem. Let me maybe talk about detoxification maybe of the body. Most of the times when, I remember when in primary school, we used to be given some very big pills to detoxify your digestive system. But you'll find maybe after school, you've not even thought of going to do it yourself. And that's a way of you ensuring that you also take care of the preventive side of it. Before a problem comes up, you've already known about it, and then you can be able to know what to do. Because when I'm aware of I have a such and such condition, it's very easy for me to know what is the next measure I'm going to take. Yeah, so thank you. I think that's what can add on that.
Right, thank you. I know there's someone who wants to speak a little bit as well. And just before she goes, this is just me asking, specifically with supplements, should those be on a doctor's advice? Because how do I know what my body is in need of, what it's deficient of? Yeah.
Thank you so much for the question. As most of the supplements, how our supplements work, is that yes, we have some doctors that you can be able to be checked. Sometimes you might come to me, I have this condition. Since I'm not a doctor, I cannot be able to tell you that this is what you're supposed to take. But for my own small knowledge, I'll tell you there's this and this, but you have a doctor, you can come, get yourself checked up, then the doctor might tell you which one and which one you can be able to get for yourself.
All right.
Yes.
So I think, taking the supplements, but from a position of knowledge of what your body is in need of. Because I think there's also now wellness crazes, and everyone is like, take this, take that, take vitamin this, vitamin that.
Yes.
It's like, okay. And as people have like a literal, box of pills, and it's not for any condition, but it's just supplements. It's like, okay, could you also be undoing some of the work that your body is doing?
Can you overdose on supplements?
Yeah, can you overdose on supplements?
But is it also an age factor? I wonder, even as Mariam asks, is it that at a certain age, you need to consider starting supplements, or is it also just on medical awareness? I wonder.
On age factor, most of the times, I think supplements, you can be able to get them at any age. Basically, like since nowadays, it's not the same as a few generations ago. Mostly for like the kids nowadays. If that person is maybe after school, they're on either they have their phone, maybe the parent have gotten them a phone or a tablet, or they're on maybe a TV, and sometimes the kids might not sit at the sofa. They'll come closer to the TV because they want to see the cartoon very well. So sometimes there are some few supplements for the kids. You also have, and basically the supplementation is more on ensuring the nutrients that you're missing, and the age also matters because maybe somebody who maybe they have aged. They also need the supplements to boost their immune and so on and so forth. And also maybe sometimes for mothers when they give birth, there's that calcium, so they also need to add on top of the same. Yes.
Thank you. I know she wanted to speak as well.
Okay,
and
thank
Stella.
you.
Yes.
Thank you for the opportunity. My name is Rose. I also work with BF I wanted to add on what he just said on educating people about the supplements. Yeah. On education, you will add more educating people on their lifestyle, because you'll find that the lifestyle, the most diseases, they are brought by the lifestyle we stay. Okay. So this lifestyle, as much as you educate people on health, you educate them on the lifestyle, because the most food we take, they're not healthy. And most people want to take like the sweet food, they want to take like everything. When you tell them don't take the white rice, and the white rice is the one which they need more. They feel it's much tasty when you compare it to the brown rice, but they don't get the importance of taking the brown rice. They want to take the sweeter rice, which is the white rice, and it's not important as you compare it to the brown rice. Yeah. So you educate people on, basically, more importantly, on the lifestyle people live, and also educate people on, mostly children. You tell them that it's not good to take so much sugar. They don't know taking too much sugar will cause diabetes. They don't have that knowledge. So when you tell a child, normalize taking a very little sugar, as much as you take sweet, don't take them every day. Don't take them frequently, because as much as you take these sweets, there's this disease called diabetes. And diabetes is this and this. Most children don't know there's diabetes, because in the ancient days, Kitambo, people were told that diabetes is for the old. But nowadays, diabetes, everyone gets it. Even the children, even the young people and the old. So when you give this information when people are young, they'll be able to know, like, yeah, there is this, there is diabetes, there is this and this, and it's brought by the lifestyle. So importantly, mostly you teach people about lifestyle. Okay, thank you.
Thank you. I know Stella also wanted to speak. Sorry, Latif. Stella wanted to speak just before we go into it. And then maybe just to pick on from what you said, I think it's great to tell kids, do this, but they really do learn from watching more. So you can say, don't, but if you're doing it, all the best convincing them.
Okay, thank you. On the conversation about community awareness or creating awareness, what I'd like to say about that is in the rural setup, they're more open to community dialogue days and community action days because they also have the community health volunteers or the CHVs who are very active in the rural setup, and they ensure that they tell the households that there's something coming up. But there's a big gap in the urban areas who very many people I've asked a number of people, and none of them, most I can count in my hand how many have said they have seen a CHV in their house. It's very few, but in the community they are so open to them, and through that awareness and through the dialogue days and the action days that you also mentioned that screening is done, whether or not they attend, and probably they get screened and something comes up, the gap that comes after that is if they're referred to a facility to get treatment, there's a gap in the availability of tracer commodities or items that are expected in a facility for the service delivery to be complete. There's a very huge gap in the facilities that we have because they do not have the medicines that they require to offer the services. Someone will be screened, but you'll be told to go all the way to town, of which in the community, in the rural areas, that's a very big distance. They'll probably walk or not even manage to go to the facility to get what they need to be able to be treated. So the gap is in the commodities and the medicines that are there in the facility. The other thing that I also wanted to say is when it comes to awareness, we have realized that in the community, that approach of community days and action days is working. But should the approach in the urban areas be changed? Because in the urban areas, rarely will you hear of an action day or a community or a dialogue day that has been set up and people have actually attended. So should the approach basically be changed to reach more people? Because in the urban areas, the population is very high. Probably the approach should be changed because in the community, the approach that is there of the dialogue days is working. And the gap of the commodities in facilities should actually be bridged. Thank you.
Thank you. Thank you, Stella. I want us to take a break. We'll be back shortly and continue this conversation. We are at the KICC at the Nation Health Summit. Come and join us. Come and enjoy the services that are being offered here. There's some free services. Free cancer screening is taking place. Free eye check, free STI screening, testing and treatment. Confidential, of course. Free HIV testing and counseling. Or confidential, of course. Free basic triage services. Free emergency rescue support. All of this, you'll find it here from various providers who are participating in this year's Nation Health Summit. We'll be back shortly. The Mike Ikukwa ground at the KICC, and we are discussing universal health coverage.
Like
and
that.
Somebody on social media is saying, I like the conversation that we're having, and but on the issue of the supplements, I'd like to get to hear from the doctors present whether I should just go and buy supplements without a doctor's prescription.
Let's start over here. I think Dr. wanted to speak on it.
Thank you again, spot on. Yeah, the issue of supplements is quite critical in the economy today. And I think we need to be careful about supplements. It's not just one bullet for every disease area. And I think what will be very important is to have a conversation with your doctor. I know doctors sometimes can be very opaque. They see you there before
sometimes.
Sometimes. So I'd like to really throw this back to the doctors to ensure there's dialogue between you and the patient. Doctors need to encourage that kind of dialogue. I think in the West now we have what is called a shared decision-making process, where the doctor and the patient work together in that diagnosis and in treatment. And even if you have hypertension, they won't just prescribe the antihypertensive drug to you. They will discuss with you about the hypertension and even ask you, are you willing to take the medication? You might say no as a patient, and they'll tell you if you say no, these are the consequences. And if you say yes, here are the consequences. So I like to encourage that open dialogue between doctors and patients, because that barrier really makes patients start looking for alternatives. You know, if you block water, water starts finding meandering ways. And meandering ways would be going to the pharmacy directly, or to the Kijiji, or to the witch doctor. Yeah, so doctors, I call upon you, please be very open to talk to your patients, discuss openly. Patients are now very well educated, and they also have Dr. Google. So if you don't talk to patients, they talk to Dr. Google, and they're sent in all directions. So please, medical doctors, I request that you kindly find time to dialogue with your patient. That can save patients' lives, can save them money, it can save the doctor time in future. Thank you.
Now that you still have the mic, Dr. Mulura, before we even move it, what happens when you donate blood and a month or so later, someone close to you needs blood? The waiting period has not passed and you can't donate again. And now you donated for umati, and now here is your relative who needs blood.
Yes, that has happened to very many donors, and it's been a hindrance to donors to continue donating blood. Because they say, I had an experience, my patient needed blood, and I could not donate because I had just given blood. This problem comes upon because we have very few donors. So the first clarion call I want to make is that we need to have a lot more donors than we have today. So please register as blood donors. All of us here, please, can you promise me that before you go out of this room, you'll have registered as a blood donor, a regular blood donor. And there's a booth there from the Ministry of Health. So register and start donating blood today. Yeah, if you feel fit, you can donate blood. If we have enough blood, there'll be no situation where a patient goes to the hospital and they don't have blood. They'll always be there from somebody else. Yeah? So the first clarion call I'd like to make is that all of us should be blood donors, donate regularly. Ladies can give every 4 months, so thrice a year. Men can give every 3 months, so 4 times a year. Also, you can give platelets. If you're a platelet donor, you can give platelets every 7 days. Platelets. So cancer patients who need platelets. From the same blood. Yeah, you can actually give platelets from the blood. So you go to our National Blood Transfusion Service and say you want to give platelets. And you can actually give every 7 days, you know. You can give plasma every 14 days. So I'd like to really educate the public to ensure that the public is aware. You can give whole blood, you can give platelets, you can give plasma, and you can give it more frequently. Please be regular donors. Don't depend on your family for donation. It's wrong to be dependent on families. I know that's the only thing we have today, but we want to discourage that. We want to have people who are giving blood regularly, voluntarily. Those are the safest people, without coercion from family, without being bullied and being told you didn't give to your uncle when he was sick. So when your time comes, we'll also put you on the spot. So let us really be adequate, regular blood donors all our lives. Thank you.
Before you give the mic, I'm sorry if it's been addressed earlier, but then there's been questions around, for example, we don't have enough blood, yes, but what we do have, are we using it adequately? There's also been questions around it expires before it gets to areas in need. There's also been questions around sale of blood, or I don't know what to call it, sale, export. Are those real? Is it rumors? And then are we working on curbing if true, if that's true?
Those are very tough questions. So about the sale of blood, the answer from the Ministry of Health is that it is a rumor. It is not true. It never happened. I think what people don't understand sometimes that blood has a cost. And yes, you might give free blood, but that blood before it's processed to reach the next patient, there are costs. There are costs for testing, there are costs for the giving set, there's a cost for blood bag, there's a cost for all these ecosystems that ensure that blood vein to vein reaches the patient. And that cost has to be covered by somebody else. Yeah? Usually the government, of course, provides money, but at times the money is not adequate to cover the whole cost. Again, calling upon insurance companies, can you consider blood, that ecosystem, the giving side, everything that goes with blood also to be covered, to be reimbursed by the insurance companies? That would really help. So the issue of selling blood, that was a rumor, and the government was discounting that and said it didn't happen. Yeah.
Mr. Question?
Yes.
Thank you. Thank you. I think as we try to fix the nation, we need to ask ourselves very tough questions. And question number one, I'm asking the government. We have instances where, innocent Kenyans have donated blood, and this blood has not been screened. And why have they not been screened? Because the funder withdrew, and the government has not funded the official screener, for example, and that is the Kenya National Blood Transfusion Center. All right? So institutions like Kenyatta National Hospital is not having blood. So how do we then solve this? But at the same time, the few institutions who are able to screen, the few laboratories, 1 or 2 or 3 of them, are also partly regulated not to be able to do it properly. So where then are we going to have, a conclusion to this issue of blood? Yes, blood is there. Yes, Kenyans have donated, so they have gone to donate 100 pints of blood, but it has not been screened. The machines are stalled, the reagents are unavailable, the funder withdrew, The government is not talking about it. So where are we? I mean, now we are left with the patient asking ourselves the question, what then do we do as service providers? Thank you.
Yeah, that is truly for the government to answer.
There's a follow-up question. Mambo ya damu, my friend.
Good morning. My name is Madanga, and just on, I am a Kenyan who is enthusiastic about health. I don't sit on any board. Sorry. So, two questions. One on the issue of blood. 2023, my wife needed blood. I rallied 20 or so people to donate. We did. She used 4 pints, and then I was still charged 5,000 per pint. Maybe just be direct on why that happens. I know you're talking about cost and that, but you know, we gave 16 more pints, and then we were still charged 5,000 per pint. Number 2 is my wife got a disease after that transfusion that she didn't have before. Who is supposed to be held accountable for that? And lastly, on insurance, last question. On insurance is, I take insurance to cover my family. And my hope is I go to a hospital, there's a disease, we are treated. So in 2023, my wife was unwell, and we had insurance. We went to the hospital, we were told this disease came as a result of her being pregnant. So that, because we do not cover maternity, we cannot treat this disease that she got as a result of her being pregnant. That was a shocker. So from that day on, I decided, insurance, no. And last thing, I am enthusiastic about walking, and I've been trying to reach health providers or people so that we can raise, do 100,000 steps so that we can raise money to buy a dialysis machine for a hospital. It's not been forthcoming. So I also wanted to, just say that's one of the things I am enthusiastic about doing. But the answers, please. Thank you.
Asante. Nathan?
Also have a question.
Oh, yeah. Another one.
And also Vincent. Vincent here has been burning with a question, but we'll see how we can get through them in a short time.
You want to take all of them first, Dr. Mulure?
Yeah.
Okay. So let's just hear them and then note them down.
Okay, I have a question on donating of the blood. You'll find that most young people are not ready to donate their blood just because they are saying, if I donate my blood now, and then I have donated it free, right? Yes. And maybe my parent or someone close to me needs blood. So I'll need to pay something so that he may be able to get the blood. And then also, when that person gets like an accident or something and he needs blood, you also need to pay. And he donated, maybe he used to donate blood every single time, but he needs to pay to get the blood too. So is there something they can do to cover up those people who donate blood for free?
Santios. Right?
Vincent? Oh, it's not a question, it's a comment. Do we have room for that, or should we?
Yeah.
Okay. Okay.
Is it related to blood?
Is it donated to blood? Donated to blood. Related to blood? Okay.
Okay, so let's come back.
Let's come back to you.
Dr. Mulure first. Respond to those ones.
Oh, yeah, those were very loaded questions. And I really wish the MOH was here. We had invited MOH to come and sit with us. I think they would have been very instrumental in answering those questions, but I'll attempt. What I can't answer, of course, I'll leave it to the MOH. I wouldn't wear those shoes and that hat. Yeah, but I think, and I'm happy that blood is eliciting a lot of discussion, because blood has been relegated to the back burner for the longest time. And we have taken blood for granted. When you talk about anti-malarials, everybody comes out shouting. HIV, drugs, TB, it's out there in the media. And we talk about and shout about it. But blood, you find sometimes you just relegate it to the back burner, you don't talk about it, and it's wished away. Yeah, and it keeps on coming back. So I'm really happy that this conversation is eliciting a lot of excitement on blood. But I must say that there's need for blood financing. Yeah, that's critical. Today we don't have enough funds. And unfortunately in the past we allowed donors to support us in that ecosystem, which I think was quite a stretch. And when they pulled out, you could see the problem that came up. So we have to discuss blood financing. Where you talk about payment for blood, I think that is officially not recognized. You're not supposed to pay for blood. It's free. And it's free because the National Blood Transfusion Service has put in place infrastructure to test the blood, to process the blood, and to distribute the blood. So officially, it's not supposed to be paid for. If you're paying for blood, then you need to raise your hand up and ask the BTS service to really check that and look into that. I also think that SHA could play a role. SHIF could play a role.
SHA.
Yes, yeah, SHA could play a role because blood becomes very much important for the support of patients in the public sector. And I suppose maybe in future we can have this conversation with SHA to see if they can step in also to provide finances for blood. I think that would be a good win for the country. Yeah, I think I'll stop there. The rest, MOH will come and answer.
Asante, we have just a couple of minutes before we wind up the conversation. So let's expand it. The backbenchers had comments and issues to raise.
Yeah, I'm Kutai Vincent, a public health professional, and they've said Mike kwa ground, so we are on the ground. I'm quite passionate about preventive health, and I wanted to contribute to the discussion that was going on in terms of preventive health. And there are two instruments that I love. In my practice, I've learned we have a thermostat and a thermometer. And the difference is a thermometer just measures what is happening. It measures temperature, but a thermostat decides to do something about it. Most of us, when it comes to our own health, we are thermometers, and we must agree to that. For those of us above 30 years old, we know we bear the heaviest burden to this country's health system. Over 70% of the health costs actually, they come to us. But at 30 years old, we also understand that we are aware of most of these things, but still we decide not to take any kind of action. We blame the government, blame our neighbors, but the responsibility is basically with us. I want us to learn how to treat our bodies the same way we treat vehicles, because our bodies are simply vehicles that just move our souls from point A to point B. When we are born, we board these vehicles, and when we die, we get out. So the same way we take our vehicles for checks. Anytime you feel there is something that doesn't feel right, you have to take it for service. We need to treat our bodies in the same manner. I've made it simple. Thank you.
I think you've said it very well. Every time we end Mali, one final comment as we conclude.
Thank you very much for this wonderful opportunity. My name is Juliet Tuokemina. I'm in the media consultancy space. So I want to pick up from what he said about intentionality and also personalizing health, UHC. It is very easy for us, and being in the media space where I am versed with matters of creating awareness, it is very easy for us to point fingers and say UHC belongs to the government or the other burden bearers or the duty bearers. But remember, it starts with you. Just picking up from what he said. My mind is taken back to, I think it was August 2023 when there was that WorldCoin craze thing that was happening right here at KICC, where there are crazy lines going almost all the way past City Hall. Or whenever we have something like a safari rally being launched here, the queues are crazy. But now that Nation Media Group has had the burden to create awareness and also create a platform where partners can come together and talk at length about health awareness, I'm not seeing the same kind of response from members of the public. So for me, it is a challenge to all of us. Like when you get such opportunities, just personalize it and be intentional. There are so many healthcare checks that are being done here. It will be good for us to be ambassadors coming from this forum today and also moving forward. When we go to our home or the various spaces that we sit in, it is important to continue with this conversation, and I believe that is how we create awareness. Thank you very much.
Thank you. Very well said. Basically, the language here is, ukipita mahali, ingia, pima pressure, you know, like that. Boss ebu niangalilie mbele. Same way you do with your vehicle, it's the same way you should do with our health, right? And the doctors and the medics here have told us today, I mean, let's just all take individual care of our health. Asante sana for joining us today. The mic has been on the ground, breaking the health barriers, having conversations around health. Tomorrow we're back to the studio, but this is what we do. It's one conversation at a time. That's how we hope to fix the nation, all of us together. It's Eric Latif, Janet Bogwa, Mariam Bishar, and our audience here this morning who have been having a conversation with us. Let's clap as we say goodbye. See you tomorrow.